Thank you, Dr. Guagueta, for that exciting talk on early stage breast cancer. Hi, everyone. Thanks for joining me today. I'm Irene Kang. I'm a medical oncologist specializing in breast cancer at USC, University of Southern California. I'll be talking to you today about metastatic disease, and I'm really excited to be part of this conference on diversity and equity in healthcare. So we're going to focus on those issues in diversity as well as disparities within metastatic disease. The title of my talk today is Metastatic Disease, Late Diagnosis and Increased Recurrence Rates. So as we're talking about metastatic disease, here are some of the topics we'll cover today. One is what are cancer disparities, and specifically breast cancer disparities. We'll then focus on breast cancer stage and how it relates to survival, and then metastatic disease and how it relates to mortality. We'll then focus on how metastatic disease is treated, the goals of therapy, and finally we'll finish up with what we can do. So let's start with a brief description of cancer disparities. The National Cancer Institute brings up 4 points that I think are really important to ground us in our talk today. First of all, we know that cancer affects all population groups, but certain groups may have higher rates of cancer diagnoses, deaths, and complications compared to other groups. And herein lies the disparity. Secondly, disparities are frequently seen associated with socioeconomic status, racial and ethnic populations, and certain geographic locations. An important point is sometimes we see that cancer rates or outcomes are improving overall, but those improvements are delayed in some groups. And so that is also an area of disparity that's important to focus on to equal the level of healthcare delivered across the board. And then I think this is a really important point, but we classically think of disparities in the context of race and ethnic groups, and I'll focus on that today because there's a lot of data behind this, but we need to remember that other groups can experience cancer disparities, such as groups defined by disability, gender and sexual identity, income, education level, and even age. So let's get into some specific breast cancer information and disparities. I'm going to focus, as I mentioned, on some ethnic disparities. So we can see here across various age groups, the incidence rate or the rate of new breast cancer diagnoses, as well as mortality rates, the rate of deaths due to breast cancer by ethnic identity or racial identity. And the blue line here is patients identifying as non-Hispanic white. And we can see that across different age groups, rates of breast cancer diagnosis was highest for non-Hispanic whites, followed by Blacks, and then American Indian, Alaskan Native, Hispanics, and the green bar is Asian Pacific Islanders. Now, when we focus on mortality rates of breast cancer deaths, there's a switch here. We see that the red line representing non-Hispanic Blacks across all age groups has the highest rate of mortality, followed by whites and the other ethnic groups. So I'd like to focus on that. Here we see kind of broken down between just the top line, which is patients identifying as Black, versus the bottom line, whites. The rate of mortality per 100,000 deaths was lower in whites, 20.6 compared to 28.9. And what that meant was that Black women were 41% more likely to die of their cancer than white women. That's a pretty significant difference. And we might want to think about why that is. So a couple more facts about some of the disparities we see as related to race in breast cancer. We see that Caucasians, or patients identifying as white, had the highest rates of hormonally driven, hormone receptor positive, HER2 negative breast cancer. These are cancers that generally have better prognosis and better long-term survival. Contrast that to African Americans, who we just saw have the highest rates of mortality and then the highest rates of I would couch this as a group of cancers that tend to be aggressive or have poorer outcomes. So highest rates of triple negative cancer, highest rates of advanced or distant stage, and we'll go over what that means in a little bit. As well as highest rates of undifferentiated grade tumors. These are generally tumors that behave aggressively. I'd like to also say that, again, from the NCI, National Cancer Institute, other risk factors associated with disparities include genetic and biologic factors, and importantly, healthcare access, socioeconomic factors, exposures, and then lifestyle qualities like diet and physical inactivity. So here's the big question. What causes breast cancer mortality? What causes deaths from breast cancer? And by and far, the main cause of breast cancer deaths is metastatic disease. So metastatic disease, what is that? That is when the breast cancer has spread beyond the regional area, beyond the primary breast and nearby lymph nodes to other parts of the body. Most commonly, those other areas of spread include the bones, the lungs, the liver, or the brain. And unfortunately, currently metastatic breast cancer is considered incurable. Contrast that to local and regional disease that we just heard about. So local and regional disease, includes disease that is confined to the primary breast or the regional lymph nodes associated with drainage from that breast. And so local and regional disease correlates to early stage and disease that is essentially curable via usually multimodal therapy, including surgery, as well as other adjuvant therapies. So when we look at survival by stage, we can see that early stage disease, which includes local and regional disease, has really much better survival than stage 4 or metastatic disease. So as the cancer develops ability to spread either to regional lymph nodes and finally distantly, stage 4, survival really drops precipitously. And so to improve survival, we have to cure women and we have to treat women at early stages. Stage 4 is an incurable disease, like I mentioned previously. But I would like to take this to talk about what we do for metastatic disease. Although it can't be cured, there are many effective therapies, and the survival with metastatic disease, although not considered long-term, really varies greatly. So on average, we might say all comers with metastatic breast cancer might have an average survival of between 2 or 3 years, but some women are able to have many years of relatively good survival. And unfortunately, some women have or some patients, not necessarily just women, but some patients have breast cancer that unfortunately has a much more aggressive course and a shorter survival. So when we think about how we treat metastatic disease, the goal of treatment is no longer cure, but it is to both prolong life or survival, as well as improve symptoms with the disease. So you can live with your cancer for as long as possible. I'd like to highlight that the cornerstone of therapy is medical treatment in this case because it's a systemic disease. And so that can involve chemotherapy, targeted therapies, endocrine therapies, and more recently, immune therapy in specialized cases. Another important thing to know is that across the board, but particularly in metastatic disease, because we do have unmet need here, is that ongoing research is looking to improve outcomes in developing new treatments. And so patients can access these treatments most commonly via clinical trials. So what can we do about the problem of metastatic disease? Like I mentioned earlier, later diagnosis and later stage puts women at higher risk for eventually developing incurable disease. And so one of the best ways to prevent a death from breast cancer and prevent metastatic disease is to diagnose it early. Screening programs and other measures that we initiate can ensure that we find cancers at an earlier stage and that are still curable. Primarily, the cornerstone of screening for breast cancer is screening mammograms. And so I want to encourage the group to get out into your community and make sure that every woman who is at risk for breast cancer, and that's almost everybody, or every person who's at risk for breast cancer really, gets appropriate screening. This should be followed by really close involvement of your primary care provider, whether that's your gynecologist or your family medicine doctor, but doing a real risk assessment. What is my family history? What is my personal risk for breast cancer? And then breast exams are also usually involved in regular physical checks. The other piece about preventing deaths from breast cancer, preventing metastatic disease, is decreasing the recurrence risk. And I think a big part of this is communication. So once a person is diagnosed with breast cancer, we have evidence-based treatments that can decrease the rate of recurrence. And most of these treatments are short-term, but some of them, like endocrine therapy, are long-term. And all of these things are an investment on the patient's part. And so it's important to have an open conversation with your care provider and ask questions about what matters to you. Is it, I want my cancer risk to be as low as possible. I want to maintain good quality of life. What's going to happen to my hair on chemotherapy? Make sure you understand what is the role of each of your therapies, as well as what are your options. And here your healthcare team has been involved in walking patients through this journey, but so have patients themselves, and they've joined support groups, and patient advocacy networks are there to help women and patients get through this journey. And finally, I'd also like to say clinical trials are there, just as in metastatic disease. They're also there to decrease recurrence risk and help patients tolerate their therapies better. Apart from medical therapies, radiation therapies, surgery therapies, there's also lifestyle modifications that we can encourage our community to engage in to both promote wellness as well as decrease the risk of recurrence. And so these are things like physical activity and maintaining a healthy weight and minimal alcohol intake. And then getting back to metastatic disease, we can still improve outcomes here. So again, I think communication is a cornerstone to the best outcomes. And so optimizing communication with your healthcare team includes really letting them know what your personal goals for therapy are, utilizing your support groups and patient advocacy networks. And then again, wellness is really the key. And so maintaining overall physical and emotional health will help you do better with your therapy. And also, I mean, that is ultimately what your therapy is aimed at, improving quality of life and quantity of life. And then again, in metastatic disease, consider clinical trials, because that is how we improve on our current treatment options. So in summary, metastatic breast cancer is contributed to a lot by late diagnosis and increased recurrence risk. So breast cancer mortality, again, is driven by metastatic disease. So to reduce breast cancer deaths, I'd like to encourage everyone to engage in screening and preventing late diagnosis, as well as optimizing treatment or appropriate treatment, and that's to decrease the recurrence risk. I'd like to acknowledge that this is a multidimensional, multifactorial effort. We need to do things creatively, differently, and with open communication if we want to reach everyone, if we want to reach a diverse population. So those are my two takeaways for the talk today, and thank you for joining me.